The next speaker is Françoise Laroche. She is a rheumatologist from Paris, and she is president of CEDR, the Cercle Études de la Douleur Rheumatologique, and she is going to speak on chronic low back pain patient management, psychoeducation programs, is there an impact on disability and sick leave days?
Yes, okay, thank you. So as a rheumatologist, I will be focus my topic on clinical issues and challenges. So it will be a little bit different compared to the previous presentations. So first of all, I would like to show you the kind of program we propose for the chronic low back pain patients, and then I will discuss the issues and challenges, and then we'll talk about cost impact if we can have some data. So, can you tell me for the next slide? Is it okay? So, is it? Could you? Okay. So, because nobody told me the way to. The next one is on the green. Sorry. So it should be this one. So I will. During the technical issues, I will go on. So probably, as you may know, chronic multidisciplinary. Okay, thank you. So this is this way. Okay, thank you. So we have noticed that many data have been chosen that chronic multidisciplinary interventions are effective in the management of chronic pain. We have shown also the results on chronic low back pain, but I don't know why it doesn't want to go on. Maybe there's a direction. So it's the same with chronic low back pain patients. Yes. Is this one? Yes, I've done. So among chronic low back pain patients, it's the same. It's effective, and you can see here the different outcomes, such as pain intensity, which is a slight effect, but we'll discuss on that later. Cognitive coping also, behavioral expression of pain, health-related quality of life, and also depression. So we have now many international recommendations that show that this program are efficacious for chronic low back pain patients, European ones, American, and also French data. And so you'll see later the slides, sorry. And what we know for this recommendation is that it's useful when it's a biopsychosocial model, not biomedical model. So we know that back pain, school pain, or back school pain does not function because it's a biomedical model. So it's not enough to take into account all the dimensions of the chronic low back pain patients. So, thank you very much. New battery, way, fine. So, I'm going on. So, the key question is, what are the elements that could lead to patient improvement, and the way we can improve our program. When you see early in the disease, it seems to be a very big topic that we don't have in our program because it's different from what has been previously shown. Our patients are suffering for a medium time of 7 years. But to propose this program early in the disease is quite very important. So there are other issues that I will talk about later, but you should just see that patient characteristics is very important. Targeting the treatment on specific patients' qualities and dimensions is very important. Of course, the therapist's skills and also outcome. I would like to focus now on outcome because we all all knew that pain intensity was a very important outcome. Probably it's very important for acute pain, but not for chronic pain. And many new research and data and studies have shown that pain intensity is not working a lot during the course of the therapies we can propose, this biopsychosocial therapy, but the patients are very happy because the patient outcome reports are very increased. The PGEC, as you see, patient global impression of change also, and satisfaction. So we have to remove probably the pain intensity as an outcome for chronic pain patients, I mean. So our program, I will try to describe this program, is existing in Paris in Saint-Antoine Hospital University for more than 20 years. François Bourreau was one of the leaders of this program. This is an intervention 8-week, 2.5-hour session program, maximum 8 patients. The patients will have some education, cognitive behavioral therapy, and physical exercises in a multidisciplinary and multi-professional way. We are three health care provider, rheumatologists, physiotherapists, and also psychologists. We do this program for chronic low back pain, but also for fibromyalgia. So you can see the outcome we have measured, which are, of course, I won't be there, relevant, I think so. And we have changed this outcome when the years were going on. So what is the patients we have in front of us? It's a patient with 3 main dimensions disabled. First of all, cognitive distortions, which are very important to deal with because patients seek, for example, to a cure for their pain, which is not the objective for chronic pain, for chronic disease in general. They also have distress and fear. Like you know the model of John Vlaien, which has been published more than 10 years ago. It's a fear avoidance model, which leads to avoidance, disability, loss of work, and so on, specific for chronic low back pain patients. And the third issue is pain behaviors, which are well known in patients, but also since a few years for the healthcare providers. They also have pain behavior for their patients. For example, they're afraid for them and they prescribe sick leave days, for example. So we have to take care about patients, but also about physicians, nurses, physiotherapists, and so on. So the most pain behaviors well known are on activity and work, of course. So our patients are disabled because I told you there were 7 years mean evolution of pain. So it's not a prevention program. It's a program very late on the disease course. So the patients should be, of course, motivated. It's a key dimension we need. So we have introduced some elements to increase this motivation to come to the program. And as you can see, they are outpatients, they come from home every day, and they are referred by one of our physicians to come. So the non-inclusion criteria are red flags that you mentioned previously, meaning patients who don't suffer from chronic low back pain, we say commune, or who can't join a group. So our objectives for the patients are to increase understanding, because I told you there were cognitive distortions which lead to disability, also to decrease fear, catastrophizing, and increase restore function, and to restore some psychosocial relationships and work, of course. But it's quite difficult for these patients who go back to work when they are disabled for 7 years. So we try to target therapy on patients' characteristics because, as you know, patients are all different and they have some dimensions which are more disabled for some of them. And we have introduced something very important. So now I will focus on 3 points. The first point is a zero session, which didn't exist since for 5 years. And we have included this session, which is a very important motivation session, which explains our goals and which discuss with patients' goal. Because if they want to enter in the program and cure completely the disease, it will need motivational interviews before entering the program. So the second point is very important, is to decrease fear and avoidance in order to increase activities, back to work, back to physical activities. And the third point is to increase self-efficacy and decrease hypervigilance and anxiety, because these patients are very debilitated and distressed, and they need to have some problem-solving help, work on acceptance, on different cognitive and coping issues. So, how can we improve clinically? I mean, first of all, our interventions is, of course, to select the patient as earlier as possible and to propose targeted therapy on the patient's characteristics and to find the most responder to different kinds of therapy. We say in French complementary complementary therapy and not alternative, because alternative means that you stop everything beside, which is not the case for us, because they still go on with medication and so on. So we have in French a politic on these issues. Since 2008, our Ministry of Health decided to implement as much as possible these psychoeducation programs in different departments, private and public. So we have French guidelines since 2008, which lead health providers, very practical, concrete propositions. So we have many guidelines that I show you now. It's a little bit small, I'm sorry. And all this was implemented by the French Haute Autorité de Santé, which is similar to NHS for the UK, for example. And we also have the Agence Régionale de Santé, which gives the money. So she decided to make program agreements in order to know what kind of programs are done here and there, and to give all the data necessary to create a program. So this agreement is done, and each year you have to give data on your program follow-up, and this is very precise, what kind of work, how many health providers and so on are implicated in this program. So we have some French data regarding cost impacts. And first of all, before to mention this study, I just want to tell you that we have many data, but these data are open, non-controlled, and sometimes retrospective. But the French prospective parallel randomized data was published 2 years ago by a team from Angers, which is somewhere in French, so Angers, and the 132 patients have been included in this program, and the first group received a restoration functional program, which is an intensive program of 6 weeks, every day, 6 hours a day, restoration, cycling, everything for activity, physical activities, but also social activities, psychotherapy, associated dietary information and so on. And they compare to a group like we say usual treatment, which means 3 times a week physiotherapist outside the hospital. They compared the two programs, and I've seen that pain intensity, flexibility, and many clinical data improved in the first group, in the intensive one, and also that there were a dramatic decrease of the number of sick leave days from 37 to 72 compared to the group during the first year. And when you know that the patient 2 years ago had around 150 days off per patient, it seems to be very interesting, very promising. So I won't go to other studies because Claire Willem, coming from Sweden, will show data probably from Stephen Linton, which is very nice. No data. Oh, pity, because they are very interesting data, international data, specifically in Sweden and also in UK. Thank you very much.